Dear colleagues, it's really a great pleasure and an honor to welcome Professor Priya Pais with us today. I met her many, many years ago at Northwestern University when I was invited there to give a lecture by her chairperson, who's Dr. Craig Langman. So I know she's very well trained in that respect. I still use him as my mentor. And she's not unfamiliar to me. And although I must apologize for that lunch, I didn't mean to be rude. I'm a vegetarian and all of them were forced to eat vegetarian meals. So anyway, Priya, welcome. And it's really a great pleasure to have you with us today. As you know, she's Associate Professor of Pediatrics, and she is from the St. John's Medical College Hospital in Bangalore, India. She completed her undergraduate training even at that hospital, then did an internship at the Illinois College of Medicine in Chicago. And then this was followed by her residency in Wisconsin Children's Hospital in Milwaukee. And then she went back to Northwestern University to complete her fellowship in pediatric nephrology, and also has a Master of Science in this. She is a well-accomplished academic with several publications in peer-reviewed journals, and I must bring this to light that she's got 5 chapters in the textbook of pediatric nephrology. Well done, that's wonderful. Okay. So with that, Priya, I want to say welcome, and it's really an honor and a privilege for us to have you with us today, and we are looking forward to your talk. But just before you start, may I have a humble request to all of you on the call that if you are not talking, please mute your mics so that we don't get any background noise. And also, Priya, I'm going to turn my video off because my internet is a bit unstable, if you don't mind. Okay, and then I'll come on as soon as you finish. Priya, all the floor is yours. Thank you.
Thank you very much, Dr. Bhima. And I'm glad, I'm so impressed that you remember me from our brief meeting as you said, many years ago. Makes me feel old now. Thank you very much for inviting me.
I feel ancient.
And I remember having a very pleasant meal with you and Dr. Lloyd, of course. Thank you for inviting me, sir. You were one of my teachers when I was a student, and so it's a great honor to be part of your group. I also wanted to share that my experience will be reflective really of, even though I've trained and practiced in the United States, I moved back to India in 2013. And so I'm very much representing conditions as they are in a low resource setting. And I'll tell you a little bit about our center later on. And I'm sure that many of you all in the audience also may face similar challenges to what we do in India. My experience with Africa has been a visit to, 2 visits actually, to Addis Ababa, because we were in a ISN sister center partnership for 6 years with pediatric nephrologist, Dr. Abebe there, Beza Abebe, and we took it to level A. And so I had the opportunity to go to Addis Ababa twice and realize that many of the challenges are quite common. So with that, I will try and share my screen. Okay, so I'll be talking about a very pediatric problem, vesicoureteral reflux in children, and really discuss some practical issues in management. So our objectives really for this session will be to understand about vesicoureteral reflux and scars that are often associated in the kidney with it, to discuss some common conundrums that we face in the diagnosis and management of reflux, and also to discuss that while there are many guidelines that tell us what to do, we really have to often adapt them to our own settings and take a very practical approach. So I'll begin with a case. The case is a typical child that we would see in pediatrics with a UTI, a 10-month-old boy with history of fever for 3 days. His urine microscopy showed pyuria, and his urine culture showed an E. coli of more than 100,000 colonies per ml. An ultrasound was done, which showed 2 kidneys of normal size and echogenicity. No hydronephrosis was present, no stones were noted. So really a normal ultrasound. As is typical with our patients, he had a history of fever in the past without a focus that was not treated at our center. He was from a rural area. He was treated with antibiotics, but no urine tests were done. So we don't know if that was a UTI. And nobody seemed to have an antenatal ultrasound report, but apparently it was okay and the child had a normal birth history. So the questions that come up really are, in this child with a UTI, febrile UTI, what is the likelihood of vesicourethral reflux? Should vesicourethral reflux be diagnosed? Is it worthwhile diagnosing this condition? What imaging would be needed to diagnose it? Do we really need to do an invasive test like a VCUG? If reflux is present, should we give antibiotic prophylaxis to the patient? And what are the other aspects of reflux management? So very briefly and very simplistically, reflux is the backward flow of urine from the bladder to the ureters and to the kidney as well. When the primary problem is due to the inadequate closure of the ureter by the bladder muscles during voiding, then it is known as primary vesicourethral reflux. However, if the reflux occurs because the bladder pressure is too high during voiding, that would be known as a secondary reflux. And that can occur in children in cases of posterior urethral valve or neurogenic bladder, really when the bladder is not working or emptying properly. So this talk will focus on primary vesicourethral reflux. So as we discussed, primary VUR really is because the ureter is not closed off during voiding by the bladder muscles. So in this slide, you see what a normal track of the ureter should be. The ureter should be going submucosally in the bladder muscles along the path of the green circle. If it has a very short course, and if it is a relatively horizontal course, then the bladder muscles don't squeeze it shut when they contract during voiding, and the urine can flow backwards. And so that is the pathophysiology of primary vesicourethral reflux. As the child gets older, it is possible that the ureter elongates and the coordination of the bladder muscles contracting during voiding improves. And so therefore many children with vesicourethral reflux actually just grow out of it. And we'll talk more about that. So our question was, what is the likelihood of reflux in this child, our patient with a UTI? Of course, healthy children don't have VCUG, so we don't have a prevalence really in the healthy pediatric population. It's estimated to be around 1 to 2% in children without UTIs. In children with UTIs, the prevalence we estimate would be around 35% in infants with a febrile UTI, and lower in older children who have a UTI, maybe around 10%. Again, children who have siblings with VUR have a 30% chance of having reflux. And also, if an infant has a history of antenatal hydronephrosis, then the likelihood of having reflux would be around 10 to 30%. So in this patient with the UTI, an infant, he has probably a 35% chance of having vesicourethral reflux. So reflux comes in different grades of severity, and this is the standardized scheme for grading in the International Reflux Grading System. The very mildest grades, grade 1 and 2, do have backward flow of urine from the bladder to the ureter and up into the kidney, but there is no dilatation or no hydronephrosis. From grade 3 onwards, there is dilatation of the ureter. Then it progressively gets worse. So the calyces are more and more blunted until you see a very dilated, tortuous system with grade 5 reflux. This is the VCUG view of what reflux would look like. And it is important to remember that a VCUG is really the gold standard for diagnosing vesicourethral reflux, even though other imaging techniques have been tried because they are less invasive. So as you can see in panel A, this is low-grade reflux, grade 2 probably. There is not much dilatation of the urinary tract. The calyces are nice and sharp. So this is low-grade reflux. The B and C are high-grade reflux, and you can see in panel C, there is a dilated tortuous system with urine just sitting there. Even during voiding, urine can flow backwards. And so this is the worst grade of severity of reflux. On a VCUG, one can also see the outline of the bladder, which is important to note, especially when one may be suspecting a secondary cause of VUR. So we talked a little bit about the spontaneous resolution of VUR. The rule of thumb is that low-grade VUR, unilateral reflux, and in children where it's diagnosed at a young age, they are more likely to resolve. This graph shows the timeline of reflux resolution. And what we can see here is that 50% of grade 3 reflux will resolve and 50% won't. However, grade 5 reflux, spontaneous resolution is extremely rare. So the higher the grade of reflux, the less likely it is to resolve. So some of the factors associated with reflux resolution, spontaneous resolution, are high-grade reflux, bilateral reflux, reflux that occurs during the filling phase of the VCUG. That's when the bladder is filling and not just during the voiding phase. Male sex, children who have a voiding dysfunction, and we'll talk about this in detail later, and those who have an underlying CACOT, congenital anomaly of the kidney and urinary tract as well. What is the relevance of reflux? Why is it worthwhile diagnosing reflux? Well, we know that, of course, reflux is associated with recurrent febrile UTIs. And this can be associated with morbidity and loss of school and work days for the parents. So it has a lot of indirect effects. Reflux is also associated with renal parenchymal scarring. There is much debate as to how much of the scarring is congenital and how much of it is acquired due to reflux or recurrent UTIs. But the fact remains that scarring is associated with reflux, and renal scarring is known to lead to hypertension and chronic kidney disease. And so therefore, most urological guidelines suggest that reflux patients need monitoring of their growth, blood pressure, and signs of CKD on an annual basis. And so therefore, if reflux does not get diagnosed, they may not receive the monitoring that they require. So a little bit about reflux nephropathy. So the traditional thinking is that reflux leads to urinary tract infections, which leads to parenchymal scarring. And this is the condition known as reflux nephropathy. And reflux nephropathy is associated with hypertension, proteinuria, and finally CKD. However, there are some weaknesses and challenges with this theory. In retrospective studies of patients who present with CKD, who have hypertension and were known to have VUR, nobody is quite sure where the scars came from. Were they UTI related or were they congenital? In children who have VUR and have been studied prospectively, the follow-up has been relatively short. So in their term of follow-up, maybe 5 years, I think the longest have been maybe 10 to 15 years, the incidence of hypertension developing and CKD developing have been low. And so we have this mismatch between looking back with a history of scarring and reflux and looking forwards, and the two really data sets have not yet met to confidently say that reflux is not associated with poor outcomes. It's also important to remember the causes of CKD in pediatrics. We all know that hypodysplasia is the commonest cause of CKD in children. We also know that hypodysplasia occurs in patients with reflux. And so therefore, in all pediatric CKD cohorts, reflux nephropathy is listed as a cause for the native kidney disease. This is some of our own data which also matches that to show that reflux nephropathy occurred in about 5% of our patients with CKD. So what's the difference between renal scarring and renal dysplasia? Scarring is a finding on DMSA that refers to a focal reduction in uptake and the loss of contour. Pyelonephritis does not have a loss of contour. So if there is a loss of contour, it indicates that there is a loss of renal or loss of nephrons really. And so this may be lead to reduced kidney function over time. Hypodysplasia refers to generalized scarring or a diffusely reduced uptake in the kidney. And so these findings both occur on DMSA. They're both related to a reduction in the contrast uptake, but their implications may be different. Scarring may be associated with UTIs, and I'll show you more data about that later. Hypodysplasia, which is more diffuse, is typically considered to be congenital. So the realistic view of reflux nephropathy is that there are many factors involved. Infections occur due to the reflux, but they also may be occurring in children who have a predisposition to recurrent UTIs. They may be genetically predisposed. They may have an underlying dysplasia. And so therefore, it is really multifactorial and not simplistic as originally believed. So we'll sidetrack a little bit just to share our data from our center. So the red dot here is our center. As you can see, it's situated in the south of India, in the state of Karnataka. And we are one of the largest pediatric nephrology centers in the country. And we get patients from all the 4 southern states, mostly rural, many are poor. And so we face quite a few challenges with undiagnosed recurrent UTI. Our strength is a nephrourology clinic where we have very standardized protocols for the last 20 years. And so when we pulled out our data of VUR patients, we found that we had almost 400 primary VUR patients with very standardized testing of an MCU, a VCUG, an ultrasound, and then DMSA scans. And so we currently are looking at the data of patients when they first presented to us. That is when the VUR was diagnosed, before any treatment was initiated. So just to focus on the red boxes, our patients were older than other cohorts, and this may be because of a delay in diagnosis of reflux. If you can look at the second red box, the most frequent way that patients presented were actually recurrent UTIs. These were children who had fever, who had UTIs diagnosed, but were not adequately evaluated. And our patient population was unique because we had a very large proportion of patients with high grade and indeed grade 5 reflux, whereas most other studies have very few patients of grade 5 reflux. So when we looked at the prevalence of hydronephrosis and scarring, as is well described, ultrasound does not really indicate the presence of reflux reliably. We compared patients with low-grade reflux, that is grade 1, 2, and 3, and those with high-grade reflux, grade 4 and 5. And yes, hydronephrosis is more common in high-grade reflux, but as you will see in the total patients, only half of them, 54%, actually had any hydronephrosis and the others didn't. So hydronephrosis was not sensitive for picking up reflux. We also noted a very high prevalence of scarring, which was 65%, and the scarring was much higher in those with high-grade reflux. What is really not so well described in other literature, we found that patients with a low eGFR, that is those less than 60, occurred more frequently in high-grade reflux, that is grade 4 and 5 reflux, and those patients who had hypertension were also much more likely to have high-grade reflux, indicating that high-grade reflux we found was associated with not just DMSA abnormalities, but also clinical morbidity. The risk factors that we found for scarring in our patients with reflux, for those who we considered to have congenital scars, that is generalized diffuse scarring or dysplasia, male sex and high-grade reflux were the risk factors that we found. For those patients with focal scars, we actually found that recurrent febrile UTIs were associated with focal but not with generalized scars, indicating again that infections do have an association with high-grade reflux. Our patients were also those who were diagnosed late, that is those who were diagnosed at an older age were more likely to have scars. This is a diagram showing the prevalence of the different grades of reflux. And we divided each group of reflux patients by the presence of no scars, a single scar, multiple scars, and in pink is the generalized scarring, which indicates a severely reduced renal function or dysplasia. And as you can see, as the grades of reflux increase, the prevalence of multiple scars and dysplasia increase significantly. So we come to, before I come to this slide, again, the question is reflux worth diagnosing? And I would say, given our patients, that definitely high-grade reflux does need to be diagnosed, because we have found that our patients do have a clinical morbidity associated with high-grade reflux and require close monitoring and follow-up. So having said that, what imaging studies should we do? We know there are risk factors for those with reflux, and the general rules of thumb for those who need a VCUG include those with antenatal hydronephrosis of a severe degree, those with febrile UTIs, those with siblings or parents with reflux, those with recurrent UTIs, and those who come in with symptoms of CKD. And as you will see, the guidelines are very variable in recommending who should get a VCUG and for what indication. So this diagram is just to show again that an ultrasound is not a good substitute for a VCUG. Yes, it is non-invasive. It does give important information, but if you look at the three circles, these are our reflux patients. In the bright green, those who have renal scars, and those who had high-grade reflux, a significant portion, that's the 70 patients in red, did not have any hydronephrosis. And so though an ultrasound is useful as a screening tool, it is not a substitute for a VCUG. A VCUG is traumatizing to the patient. It is also traumatizing to parents who have to be with the patient, and it exposes the child to radiation. And so therefore, there has been much discussion about putting children through a VCUG test. If we look at the guidelines and how they have evolved over time, the most recent guidelines really have become much more liberal and avoid VCUGs if at all possible. Most of these guidelines presented here are medical guidelines, that is, they come from nephrology or from pediatricians. And as you can see from the AAP guidelines, really nobody gets a VCUG unless it's a recurrent UTI or they have ultrasound abnormalities. The NICE UK guidelines are even more conservative with avoiding VCUGs. Unless the child is less than 6 months of age or has a recurrent UTI, children with the first febrile UTI are not considered for VCUG. And the guidelines really are similar across the globe. Our own Indian guidelines, that they are rather old and they are about to be updated soon, they'll be out in print soon, did recommend that if a child is less than 1 year of age with a UTI, they should have an ultrasound, of course, a VCUG, as well as a DMSA scan, but this also is about to. So before we decide who gets a VCUG, some important points to note is that if a child is having a VCUG, it better be done properly. So a standardized protocol is very important. I won't go through the details here. Minimizing the child's exposure to radiation, ALARA stands for as low as reasonably achievable doses of radiation. The film should be taken in the bladder filling phase, voiding phase, and post-void phase to look at whether reflux occurs during filling. The voiding phase, of course, cements the diagnosis of reflux. It also shows the urethral outline, which would help to diagnose posterior urethral valves, and the bladder outline. And post-void phases inform us about whether there is a post-void residual urine in the bladder, which could occur with dysfunctional voiding. Grading also of the VUR has to be very standardized. And so therefore, if we're doing a VCUG, it should be done at a center that is used to doing them systematically. Otherwise, it is not fair to put a child through a VCUG. Other alternatives to a VCUG, there multiple other studies have been tried. The commonest one that we use as an alternative is a radionuclide cystogram. It reduces the radiation exposure. However, the child does need to be catheterized, and it does not actually delineate the urethral outline. And so it's sort of a screening tool, but No other test really is as good as a VCUG. There are some MRI tests that I'm not familiar with, and I think they're really hard actually to come by. So should we get a VCUG? Some practical considerations. I think the biggest challenge we face in a child who has a febrile UTI and comes to us is that if we treat them and then tell them to go home and come back for a VCUG, if they get another UTI, they are not likely to come back to us. They may go to any other local center. As you can see, doing a urine culture itself is not a given. And so therefore, what are the risks from not diagnosing reflux? It could be recurrent untreated UTIs. It could be the lack of monitoring. And so therefore, I think we use our clinical judgment. If we have a family who we believe with the first febrile UTI, they can be relied on to monitor for symptoms of UTI, to reliably present for early treatment and evaluation at the second or recurrent UTI, we could wait for the VCUG. However, our threshold for doing a VCUG in our setting, low resource setting, patients coming from far away, our threshold is low. If we have any doubt, we prefer to go ahead and do a VCUG. And this is against most evidence-based guidelines, but I guess that's a practical way that we approach patients. So our patient had a VCUG. He had grade 4 bilateral reflux, and the DMSA is to be done after 12 weeks to detect scarring and so that we don't pick up pyelonephritis. So what are our options for treating the patient? Before we discuss that, our goals of treatment would be to try and prevent the morbidity of recurrent UTIs for the patient, to prevent renal damage associated with reflux, and to also limit morbidity from treatment itself. So let's look at our treatment options. Treatment option number 1 is continuous antibiotic prophylaxis. This is a daily continuous antibiotic taken to sterilize the urine. And the theory is that if the urine is sterile, even if there's reflux, there will not be worsening of renal damage. The problems with it, of course, are that we are exposing a child to a low dose, long-term antibiotic and the problems of bacterial resistance. We routinely use cotrimoxazole or nitrofurantoin as antibiotic prophylaxis, except in children and young infants where we use cephalexin. So that's one strategy. We'll discuss whether the evidence about it in 2 minutes. The second option for treatment is circumcision. So we know that uncircumcised males with reflux have an increased risk of UTI. And so therefore we offer elective circumcision to males with reflux. And the downside is that we are exposing the patient to a surgical procedure. Our third option is surgical correction. We know that open surgery, where the ureter is reimplanted back into the bladder, is highly successful. There are also endoscopic procedures that are less invasive, but have a slightly lower success rate. But do we really want to put a child through surgery for a condition, especially low-grade reflux, that may not require surgery? And so the indications for surgery really are persistent high-grade reflux, grade 4, grade 5, that does not spontaneously resolve. If children continue to have breakthrough UTIs despite antibiotic, and if on repeated DMSA monitoring, the child with high-grade reflux continues to have increasing number of scars, that are indications to surgically correct the reflux. But otherwise, I would say, for the most part, surgery is not a first-line treatment and is only performed if one of these 3 indications appear. There is no evidence that surgery versus antibiotic prophylaxis is superior. The fourth option is UTI surveillance only, and this is what is often followed in high-income countries where patients are not exposed to antibiotic prophylaxis or surgery, and they are treated if a UTI occurs. But this means that the reflux should be low grade. That is, the risk of recurrent UTI should be relatively low. The child should be toilet trained. The family must know the signs and symptoms of a UTI, and they are unlikely to disappear or to seek inadequate treatment elsewhere. And so UTI surveillance without antibiotic prophylaxis is really something that we don't practice. We put all our reflux patients on antibiotic prophylaxis, and I'm happy to discuss what you all do later. So the issues and controversies in antibiotic prophylaxis are the following. Does it really work? And so this is the well-known RIVER trial, where they looked at 600 children with grade 1 to 4 of reflux. And this was a placebo-controlled trial with using cotrimoxazole versus placebo. And they found that the risk of recurrent UTI reduced by 50%, especially in those who had febrile UTIs and those with bowel and bladder dysfunction. But the question remains, did it make a difference in renal scarring? And their results did not find, they were not powered to actually comment on the change in scarring based on antibiotic prophylaxis. Only the outcome was recurrent UTI. This is a study that was performed on children with UTI. They may or may not have had reflux. And it was a large study, looking at Septran versus placebo to look at the reduction in UTI recurrence in those who received antibiotic prophylaxis. And so they also did not find or did not really comment or were unable to answer the question of whether antibiotic prophylaxis reduces renal scarring. This is a Swedish reflux trial, and this was a different group of patients. These were many patients with high-grade reflux. They looked at antibiotic prophylaxis versus endoscopic surgical treatment versus just surveillance. And they found that antibiotic prophylaxis caused a significant reduction in UTI recurrence in girls, but there wasn't much change in boys. And also the answer about scarring was incomplete. So therefore, the RIVER trial showed no change in scarring with continuous antibiotic prophylaxis. The Swedish reflux trial showed that scarring was strongly associated with febrile UTIs, and it occurred more in those patients who did not receive antibiotic prophylaxis. Another trial called the PREVENT study showed no change in scarring, but it is important to remember that scarring was not the primary outcome of these studies, and so therefore they were not really powered to answer the question about scars. So that remains unanswered. A systematic review looked at whether long-term antibiotics were useful in preventing recurrent urinary tract infection in children. And what they found was that there was a modest reduction in the number of UTI in those who received antibiotic prophylaxis, but these studies mostly had bias and all different methods were used to answer the same question. So therefore, we come to our clinical or practical aspect. We have the evidence. The evidence tells us that antibiotic prophylaxis is useful in UTI, but doesn't make any difference in scarring. We have our clinical judgment, where we feel that, at least in our center, all our patients are on antibiotic prophylaxis. We don't face too often issues with bacterial resistance. And so therefore, I think, as all clinicians are used to, balancing the evidence versus clinical judgment is what will help you decide on a case-by-case patient what to do with your patient population. This is a suggested approach to the use of antibiotic prophylaxis. These are taken from the Indian guidelines. And if you look at asterisks, these are about to change. In the next couple of months, the new guidelines will be out. And so the old guidelines suggested that in any infant with reflux, antibiotic prophylaxis was indicated. This is about to change to antibiotic prophylaxis is suggested for those with high-grade reflux, including infants. In children who are older than 1 year and who do not have voiding dysfunction, scars on DMSA, and no breakthrough UTI, antibiotic prophylaxis need not be given. In children with high-grade reflux, the old guidelines suggested using antibiotic prophylaxis until 5 years of age. The newer guidelines are going to suggest that high-grade reflux children receive antibiotic prophylaxis until 2 years of age or until the age of toilet training, whichever is later. In children over 5 years, antibiotic prophylaxis is only indicated if bowel bladder dysfunction or voiding dysfunction is present. And we will discuss BBD or bowel bladder dysfunction and the role it plays in reflux in a little while. So bowel bladder dysfunction, about half of toilet trained children with reflux had bowel bladder dysfunction. So yes. So the simple definition of this is basically inappropriate bladder emptying with constipation. This is common really in children of the potty training age. There is really no structural anomaly of the bladder, unlike PUV and neurogenic bladders, but bowel bladder dysfunction or dysfunctional voiding perpetuates VUR. It does not allow resolution of VUR, and it's found to be a risk factor for recurrent UTI as well as a risk factor for scarring. These are some of the clinical signs that bowel bladder dysfunction occurs. These are known as holding maneuvers, where the child is trying to postpone voiding. They don't want to go to the bathroom, they're frightened to go to a new bathroom, and then it becomes habitual. Holding on to urine, this leads to daytime incontinence, it leads to urgency, it leads basically to incomplete bladder emptying, and it is very much worsened by the presence of constipation. And so therefore, if we want to manage bowel bladder dysfunction, we must first diagnose it. We have a scale that we can use to score whether the child has symptoms of bowel bladder dysfunction. We need to rule out that there are no actual structural anomalies by doing a good spinal and genitourinary examination. We need to be cognizant of the fact that we need to rule out actual bladder obstruction. But once all that has been ruled out, the simplest way to manage bowel and bladder dysfunction, I'm sorry, the order of the slides got mixed up a little bit, is to basically treat constipation, increase fluid intake, and schedule voiding so the bladder is emptied completely and frequently. And in children who have a post-void residue, is to actually encourage them to double void, that is to void and then again sit down on the toilet and void again. And this ensures complete bladder emptying and less chance of UTI. Another important issue in management is really long-term follow-up. And this is where primary care physicians, family doctors, pediatricians play an important role because they educate the family, they ensure compliance with therapy, and they can monitor the child's growth, measure a BP without them traveling all the way to visit a higher referral center. In the end, in a systematic review of what works for treating primary vesico-urethral reflux, it really remains unclear whether antibiotic prophylaxis, surgery, endoscopic surgery, open surgery, none of them were proven to be superior to the other. And that's really where the data stands. In practice, most low-grade VUR resolves on its own. We reserve surgery. In our center, we do open surgery, but other centers have good experience with endoscopic surgery as well. That is reserved for the few cases of severe high-grade reflux that don't resolve or who continue to have recurrent UTIs. So these are my take-home points. Primary vesico-urethral reflux is associated. It may not lead to, but it is associated with febrile UTIs and scars. Scarred kidneys are known to be associated with poor function, and poorly functioning kidneys are at risk for chronic kidney disease. And so therefore, I would like to say that diagnosing VUR is important. The VCUG is the gold standard for making a VUR diagnosis. Acknowledging that it is an invasive test, it should be reserved for children who need it the most, and it should be done in a standardized way. High-grade reflux is a high-risk situation clinically, and so therefore must be diagnosed. And ultrasound is not a good test to diagnose reflux or to rule it out. Continuous antibiotic prophylaxis is effective in preventing recurrent UTIs, though there is not enough evidence to say that it actually prevents progression of scarring. A simple method of management in addition to antibiotics is to rule out and treat bowel bladder dysfunction, that is dysfunctional voiding. And lastly, surgery is not essential in most VUR patients. So that's my talk, and I'm happy to take questions now if there are any.
Priya, thank you very much for that very enlightening talk. You know, it's a topic that is really difficult, given the fact that the evidence in the literature is not quite clear as to exactly what one should do in the practical setting. And so I think you've approached it very well. And I want to say thank you very much once again for bringing all those controversies to the fore. I'm going to open the floor now to questions before we go into the chat. Is there anyone that would like to ask Professor Pais any questions?
Yeah, just one question. Please. One question. Thank you very much, Priya. That was a wonderful, exposition of a very important topic actually in pediatrics, and quite a lot of this actually goes undiagnosed. I see, in this part of the world that I've seen, so I think it's a very, very important issue that was discussed. So one little thing is like the issue of when hypertension proteinuria complicates reflux at diagnosis, and if the stage of reflux is high, I don't know, Dr. Shastri, my boss in Vellore, used to say no surgery. What are your take on that?
I think because of this chicken and egg situation, I think the current thoughts are that scarring really, a lot of it is congenital. And so the focus really is on preventing recurrent UTI. There is no evidence that doing the surgery will reverse any of the changes that already occur. And in grade 5 reflux, even we with grade 5 reflux do not directly go to surgery. If the child has no breakthrough UTIs on prophylaxis, we definitely circumcise the males. We would monitor strictly for bowel bladder dysfunction, voiding dysfunction, and give them, even the grade 5 reflux, give them a period of 6 months to 1 year to show that this is not resolving and maybe even getting worse. So really there are very few patients with where we go directly to surgery. You were asking about those who probably have advanced CKD. And I think maybe in those situations where, their GFR is low, in addition to hypertension and proteinuria, we have done, and we would refer them for primary reflux surgery, where they're at great risk for progressing to ESRD.
And one more quick question is, the use of antibiotic prophylaxis is better in, it does produce a difference in the female as compared to, because the urethra is shorter in the female child, right? So is there a difference?
There was one study that showed that, the Swedish reflux trial. The other studies did not really show that there was a sex difference, though it definitely made a difference in the grade. In practice, we put all patients on it. I think girls are more predisposed to voiding dysfunction, especially the ones who are 2, 3, 4 years of age in the potty training phase. And we know that antibiotic prophylaxis is helpful in those who have voiding dysfunction, not because it fixes their voiding dysfunction, but while they are retraining their bladders, it prevents UTIs. And so I think in this female population with reflux, they I think possibly had more voiding dysfunction.
Thank you very much.
Thanks, Lloyd.
Thank you. Bima, can I
go ahead,
so
go ahead, Jana.
Thank you. Priya, thank you very much. That was excellent presentation. And just wanted to ask one question regarding the prophylaxis, antibiotics prophylaxis. For how long will you continue giving the prophylaxis for reflux nephropathy? And therefore, and during your presentation, you said you normally use cotrimoxazole and cephalexin, but in the third world countries where these drugs might be a bit expensive, though cotrimoxazole is cheap, can we use nitrofurantoin? Because I've seen some pediatrician using nitrofurantoin in children more than 6 weeks of age to 3 years of age. They're using nitrofurantoin. What's your comment on that?
I'll answer that first. Thank you very much, Doctor, for your kind comments. Definitely nitrofurantoin can be used, and we do recommend that it is used as a first line along with cotrimoxazole. It's cheap and it's easily available. And only in the infant age, less than 6 months, I think we avoid both cotrimoxazole and nitrofurantoin and use cephalexin. But nitrofurantoin is an excellent drug. And it especially works in our practice. We see a lot of complicated UTIs, those with underlying congenital anomalies. And when all else fails, nitrofurantoin, even if we get a multi-drug resistant UTI, and even if the IV antibiotics are resistant, we just put them on oral nitrofurantoin. I think it has a very good penetration into the urinary system. So nitrofurantoin is good. Regarding the duration of antibiotic prophylaxis, I'll answer that in 2 ways. I'll tell you what we do later, but according to most evidence-based guidelines, antibiotic prophylaxis is recommended until children can void reliably. That's the age of toilet training. That means when their bladder contracts in a very coordinated manner. So usually that's still about 2 years of age. It is extended in duration if the child has a voiding dysfunction. If they've got constipation, holding maneuvers, then the antibiotic prophylaxis is continued. So that's really the recommendation. 2 years, but can be continued in children who have voiding dysfunction. Having said that, in practice in our center, the antibiotic prophylaxis is sometimes continued much longer, especially in those with high-grade reflux. In our practice, we have not found too much of a problem with exposure to antibiotics. We don't screen them for bacterial resistance, but at the same time, they don't actually have many breakthrough UTIs. This is our experience. And so often they are continued until 5 years of age, especially those with high-grade reflux, 5-6 years of age. But I would say a reasonable approach is to give it until they are toilet trained.
Thank you.
Priya, there's a question on the chat from Dr. John Caroli.
Okay.
Says that, what is the prevalence of hypertension and chronic kidney disease in adults caused by scarring? And I assume scarring by reflux, the high-grade reflux, right? So what's the incidence of hypertension and chronic kidney disease?
I think there is one study that the studies that have been done on trying to connect childhood UTI with CKD really were done not in VUR patients, but in patients who had a history of UTIs. So did they have UTIs? Did they have reflux? We don't really know. There is data to suggest that UTIs is associated with a higher incidence of hypertension. Definitely the CKD population, even in young adults, is associated with CACUT and a history of reflux. And CACUT and reflux often occur together. And so I think while we may not have followed individual patients to find out the incidence of hypertension in the reflux population, I don't think there's much doubt that CACUT, which includes reflux, is associated with hypertension and proteinuria. It probably includes those who have high-grade reflux only. The low-grade reflux does not lead to much morbidity. I don't have exact numbers, I'm sorry, in the adult population.
No, I don't think so. There's any studies done to actually elucidate that. So it's very difficult to make that association because, as you said, follow-up is not long enough for us to actually come to any strong evidence-based conclusions on whether leads to hypertension and CKD in that way. If you don't mind, I just want to give you some local experience, and I'm talking from South Africa, but not, I don't know, and I'd like to hear from others what they feel. But your topic was based primarily on primary vesico-ureteric reflux.
Yes.
And I must tell you that in our local indigenous Black population, we are fortunate the primary vesico-ureteric reflux is quite rare. Okay. We definitely don't see that percentage of patients with primary vesico-ureteric reflux. We do see it in patients with CACT, in other words, congenital abnormalities of the kidney and urine tract, with posterolateral valves and other abnormalities. So we have fortunately, a very low incidence of this condition. And based on that, and the fact that VCUGs are quite invasive, in my own practice, I will only do a VCUG if I have higher grades of reflux and recurrent UTIs. I will not do VCUGs to look for reflux in patients who present with just a single UTI or where there's no ureteric dilatation or hydronephrosis. So that's a slight difference from the guidelines that you presented there. But that's because of our local experience. You know what I mean? That this is quite rare in our population. See?
I think you are very consistent.
Apart from that, with regard to continuous antibiotic prophylaxis, I must say we use nitrofurantoin because it's cheap and quite available. The other drug that I've seen some of the pediatricians using, which I don't know how available it is now, but it's nalidixic acid. And but those are used in the older patients. I don't use that, but I've seen some of them who are referred to a hospital being put on that. We have a very high incidence of resistance, unfortunately, to cotrimoxazole because of antibiotic usage and all other factors. So I must say that in the younger patients, etc., when we start prophylaxis, we usually use a first-generation cephalosporin because of sensitivity pattern. But then you got to know your sensitivity pattern. The microbiologist will help you with that to see what your local sensitivity pattern is to the E. coli and other common organisms. But yeah, thank you very much. I really appreciate that. See, is secondary reflux more common than primary reflux?
I would say that the prevalence of secondary reflux is much less common. I think in referral centers, secondary reflux due to neurogenic bladders, posterior urethral valves, the prevalence will be higher because of a referral bias. These are the children who get really sick. These are the children who progress to CKD. Yeah. So we will see a very high number of them. We had 30% of our patients with just primary VUR had some other CACUT along with it. They had like a single kidney or multicystic dysplastic, but they did not have bladder abnormalities. And so I really I think that secondary reflux due to bladder problems are rare but bad.
They tend to be more severe.
Question here, which I think I put the whole panel. Everybody listening.
Sorry, now, go ahead.
How about the long-term use of nitrofurantoin? Because theoretically, in the old texts, they have always mentioned the risk of pulmonary fibrosis. And now I don't know. It seems now to be. Two people have said it haven't. I mean, they have said it. It's okay to use it on long term. So maybe there is new evidence to that effect. I would like to be corrected on that.
I'll have to ask for your experience with that, Dr. Bhima. We don't use it. Nitrofurantoin is our first line, so I don't have much experience with.
If you don't mind, I'll answer that question. You're absolutely right. It's listed in the textbook, right? Personally, I've never seen it, and we use a lot of nitrofurantoin, right? I've never seen a child develop primary pulmonary fibrosis, but yes, it is listed in the textbook. I must say it's very difficult to monitor for that kind of thing because, we don't routinely do VQ scans and all on these patients unless they present with some serious chest problems. So it may be that it is there, but we're just not picking it up. Early enough, you understand what I mean? So it's a difficult one to say that in my experience that I've ever seen any child. I haven't seen one where, they've been given prophylaxis with nitrofurantoin and developed primary pulmonary fibrosis. The answer is I haven't seen, but I am not saying that it doesn't occur, because I must say the children have to be symptomatic before they are subjected to VCUG scans. We haven't done any studies on that, see, on asymptomatic children. But yeah, you're right. It's something that's listed in the textbook. Another question here, is there any EGFR for nitrofurantoin for every, or for every, I don't, sorry, I think is there any estimated GFR for nitrofurantoin for everybody? I don't know. Or maybe it affects it.
I think if there's advanced CKD, then we would not use nitrofurantoin.
Yeah.
Because of the reduced renal clearance.
If the GFR, especially if it's less than 60, we will never use that. Do you understand, man? So yes, that's another contraindication for its use. Well, is there any other questions before we close this? Go ahead.
Is there a role for a nephrectomy pre-transplant? What would be the indication? Nephrectomy pre-transplant in children. So current UTI or?
Are you asking, sir, for any child or on a child?
No. Pre-transplant. So pre-transplant, an indication for nephrectomy.
So pre-transplant nephrectomy in a child with reflux, we would do if it really is causing recurrent UTIs and the child is in ESRD and we don't need, the residual renal function is not as important as preventing the UTI. So we have done native nephrectomies for those who have pus bags, like basically a bag of pus that's not working. Other indications are not really related to infection. They are in those children who have FSGS sometimes, who remain nephrotic. And sometimes, rarely, in very small children to make some space. If they have high urine output, a big kidney, that's all.
Just one other thing, Priya, with regards to surgery and endoscopic surgery and open surgery, I must say our local surgeons are getting quite good at this endoscopic sting operations. And even in patients who have quite grade 5 reflux, etc., sometimes it fails and they repeat the endoscopic surgery. But we are starting to see good results now with that. And so it's quite encouraging because, these patients don't require open surgery and all the other attendant complications associated with it. So that's where we have made quite a bit of progress with regards to the management of high-grade reflux.
I think that's great.
I must say we don't ever do like vesicostomies or anything like that. I have never encountered that. I know previously when I had worked as a junior registrar, I used to see many of the patients having primary vesicostomies. That's fortunately now completely gone. Right? Endoscopic surgery is now the modality of choice.
That's great. We find that the material for the
other questions?
is expensive.
Yeah.
And so most patients can't afford it.
Yeah, okay. ID is expensive, I must say. See? So there's a question here which says, which grades of reflux resolve spontaneously? I think you answered that in the talk, but just repeat it, please.
Sure. So grade 1 and 2 are really, almost all of them will resolve spontaneously. Grade 3, 50% will resolve spontaneously by 2 to 3 years of age. So these are the patients who do not need surgical intervention. And grade 4 is lower than 50%. Grade 5 almost never resolves spontaneously, especially if it's bilateral.
Yeah. Okay, thank you. There's another question. At which point do you need to involve a urologist? The answer is not at all, but anyway, you can answer that.
So we actually sit together with pediatric
Just
surgery,
unmute yourself, please.
but we all do medical management.
Yeah, I must say, no, I do use a urologist sometimes, but for the sting operations, etc. But apart from grade 5 reflux, or grade 4 with recurrent UTIs, the rest of it are managed pretty conservatively, and many of them do very well. Okay, I don't see any problems with them. There's another question here. What's the average age for a child to develop CKD with vesicoureteric reflux?
Oh.
Tricky one.
Yes.
Just unmute yourself.
So there are many children who have underlying kidney abnormalities, what we would term hypodysplasia, lower nephron number, they may also have reflux. So in those patients, they develop CKD because of congenital hypodysplasia, and it may not necessarily be secondary to the reflux itself. And so they can present with CKD at quite a young age, starting from 5 years and upwards. And reflux is really along for the ride, it's incidental. CKD developing due to primary reflux alone is actually quite rare.
And you can pick it up when you do the DMSA scans, you know what I mean? To show that these patients have quite significant hypodysplasia. And so you know that this is the child that you must monitor much more closely as opposed to have those that have normal kidneys. See? So yeah, I agree with you there. So if there's no further questions, Priya, I want to tell you thank you so much. It was nice seeing you after very long. I haven't forgotten that. And do you still keep in contact with Dr. Langman?
Not so much. I think
Sorry,
he
I can't
has
hear.
retired.
Yes. Yeah, I email him now and then.
Yeah, I used to, but not so much anymore.
No, just on a friendly basis, not anything else. Yeah. But thank you so much, and it was really a pleasure having you.
It was great fun. Thank you.
Thank you. Bye-bye.